This is Neil Greenspan on behalf of Pathogens and Immunity, where I'm one of the senior editors. I am joined by Michael Letterman, the editor-in-chief for Pathogens and Immunity. And today we have the good fortune to host a conversation with Stanley A. Plotkin, MD, who received his undergraduate degree from New York University in 1952 and then graduated from New York Medical School at Downstate Medical Center and completed his internship at what is now Metro Health Medical Center in Cleveland, which is an affiliate of our home institution, Case Western Reserve University. Dr. Plotkin is a highly accomplished developer of and authority on vaccines, especially for viral pathogens. He played direct and pivotal roles in developing the rubella and rotavirus vaccines in current clinical use and has consulted on or contributed to many more. Dr. Plotkin has held both academic and corporate positions involving vaccine research and development. In addition, he is the founding editor of the definitive textbook on vaccines that is now in its 8th edition, and he has received many honors for his work on vaccines, including the French Legion Medal of Honor, the Sabin Foundation Medal, the Maxwell Finland Award in 2009, and the Hamdan Medical Research Excellence Award in 2014. Welcome, Stanley, and Michael will lead off with the first question.
Dr. Plotkin, thank you so much for joining us here. My first question is, what are the influences that drove you into science and medicine?
When I was 15, I read 2 books. One was Microbe Hunters by Paul de Kruif, and the other was Arrowsmith by Sinclair Lewis. And they convinced me that that was what I wanted to do. That is, to go into biological science and to work on vaccination. So after reading those books, I applied to the Bronx High School of Science, which still exists and which is a magnificent institution in New York City, and went through that institution, graduated, went to New York University, which at the time had a campus on the western side of the Bronx overlooking the river and Manhattan, etc. Anyway, so I graduated there and then went to medical school at what is now called Downstate Medical Center in Brooklyn.
I wanted to ask you, since I read Arrowsmith in college, actually, for a biochemistry course, were there any particular aspects of the main characters wrestling with research versus clinical medicine that particularly affected you?
I think what struck me in Arrowsmith was the evolution of his thinking and his direction. As you remember, the book has a lot of tragedy in it, but nevertheless, he ends up at what was the Rockefeller Institute, and he obviously becomes satisfied with what he's doing. So, it was not that I was emulating his career, but his desires were in line with what my growing desires were. And so it was definitely something that stimulated me to go in that direction.
So you've lived in both worlds, both the clinical and the research world. How do you balance the tension between clinical responsibility and scientific enterprise?
That's, of course, a very good question. And the answer is by working 20 hours a day. Interned in Cleveland Metropolitan Hospital. And I had gone there in part because Fred Robbins of the Enders Weller Robbins team was the head of pediatrics at Cleveland Metropolitan. So I figured that was a good contact for me. And then, parenthetically, I believe that chance is everything in life. But at Cleveland, I was finishing my internship. It was the time when the military service was obligatory. And so I enlisted in the Air Force. When one of my fellow interns told me about the Epidemic Intelligence Service at CDC, which I did not know about, but which I applied to, obtained entrance, and went to CDC, and that allowed me to learn about epidemiology, etc. I it's a funny story because at the end of the training at CDC, there was a list of assignments. One of them was at the Wistar Institute in Philadelphia, and it was in an anthrax laboratory. Now, I had no particular interest in anthrax, but I knew that Hillary Kaprowski had taken over at the Wistar Institute, and my reasoning was that if I went to the institute, I could get into his laboratory. So I learned about anthrax. By chance, an epidemic of inhalation anthrax occurred in Massachusetts. I went up and worked that up and published on anthrax. And then early at Wistar, I walked into Kaprowski's office and asked him if I could get into his polio lab. And he agreed. Why, I'm not sure, but he agreed. And so I got into his polio lab and started simultaneously to work on virology and bacteriology. Became involved in his oral polio vaccine, went to the Congo to test the vaccine. You know, as I said before, chance is everything in life. I was very lucky to have those opportunities and to take advantage of them.
So I'd like to transition now a little bit away from your personal history and into what you think about vaccines and biomedical problems as they are evolving. Do you have any conclusions or lessons that you take from the COVID pandemic?
What the public doesn't recognize, but which is the fact that COVID was an entirely new disease with new biological qualities. And we started, of course, with ignorance about the properties of the virus and the disease, and that science learns by experience, by experiments, etc. Now, the recommendations that were made at the beginning of the outbreak were in line with what was known at that time. The virus was quite virulent in its first manifestations. But of course, with time, the virus mutates. Mutations allow it to infect more people, but kill less. And if you want to put it this way, the aim of the virus is not to kill people, but to multiply and spread. The virus changed, and our public health recommendations changed. Now, the problem is that the public does not understand science because scientific education in this country is terrible by and large. And so they do not understand that things change and recommendations change. So now you have a situation where people are complaining that the original recommendations were wrong, which they were not. But now we have different recommendations, and I understand that. I agree, for example, that young males should not be vaccinated against COVID anymore, because if they get infected, their disease will be mild, and they probably have had prior infection anyway, and the reaction rate is significant. On the other hand, pediatric disease, particularly under the age of 3 or so, can be quite serious. And therefore, I do think that vaccination of children, introductory vaccination, so to speak, which gives them some resistance against the virus later on in life anyway, is a good idea. Now, what I'm getting at is that public health recommendations should be made based on the current facts, but the public doesn't understand that.
How do you assess the performance of the mRNA vaccines for SARS-CoV-2? And do you think there are any aspects of this vaccine platform that underperform relative to the older protein-based subunit vaccines?
Well, the induction of T cell responses wasn't optimal, and the dosage was pretty high. And we've learned how to change the technology, for example, using a self-amplifying mRNA to reduce the amount of RNA going into the patients. So what I would say is that mRNA was a great emergency response. The science can now allow for reduction of reactions, and there needs to be improvements in T cell induction by mRNA vaccines. And actually, I have written a paper titled Polytheism is Preferable to Monotheism, with the idea being that everything should not go into the mRNA basket, that we have other technologies which provide good immunity and, in some cases, better cellular immunity.
Well, with those things in mind, do you think that there are any current older platform vaccines that could or should be replaced using an mRNA platform?
Well, okay, so we have the live attenuated vaccines.
Right.
Now, they generally give both B and T cell responses and prolonged protection. So why would we replace those in favor of mRNA? Right. And there are other situations where, let's say, chikungunya, where you could make an mRNA vaccine, but what would be the advantage? You've got the live vaccine and the kill vaccine now, which are very effective. So why would you switch to mRNA?
Right. Well, what about perhaps for as an option for the rare immunocompromised patient for whom an attenuated vaccine has the risk of dissemination? Would that be a place, a space for either killed or protein-based or RNA-based vaccines?
Yeah, I suppose that would be a reasonable possibility, but you would want to know that the immune responses were sufficient with the replacement vaccines, yes, and in particular the T cell responses.
Yes.
Just the other day, I had a question about mRNA vaccines for immunosuppressed people, and the idea being that. Well, for example, somebody who couldn't produce antibodies very easily, but still has T cell activities. An mRNA vaccine would not be ideal for that person. You would want something that would stimulate a good T cell response to provide whatever possible immunity the T cells could give to that immunosuppressed individual. I think one has to evaluate each situation and decide what is the optimum.
Why do you think the T cell response to RNA vaccines is suboptimal? What underlies that failure?
My guess is that the RNA, well, I guess that's just repeating, but I think it goes to the bone marrow, and the B cell response is pretty good. But apparently it doesn't get well into lymph nodes where T cell stimulation can occur. But of course, it's not black and white. There are T cell responses to RNA vaccines, but they're not great and they don't last.
You may recall that I think during the pandemic, there was a movement, and there was even a paper in the New England Journal about the notion that you could, now just sequence a virus and generate an mRNA vaccine in 100 days and start immunizing people. I was taken aback by that because I think it was underappreciating the 20 years of research or more, depending on what you want to count, that underlay the success of the mRNA approaches in the case of COVID. What do you think about this idea that you could produce new vaccines in 100 days from the time of identification?
Well, I've been very involved from the beginning in CEPI, the organization that I and a couple of other people 10 years ago suggested needed to come into being to develop emergency vaccines and vaccines that had no commercial interest. I think mRNA vaccines are excellent for rapid response. And so if you have a new disease and you need a quick vaccine, such as was the case with COVID, mRNA is a great technology. But in the long run, you want a vaccine that is well tolerated and that gives long-lasting immunity. So my view, and that's essentially built into CEPI, is that you have an emergency response, the quickest possible, but in the long run, you try to develop a vaccine that gives you the most wide and long-lasting immunity. And so I think the idea of mRNA, let's say if a new disease pops up, is a great idea because it's quick. But you also have to think in the long run, what's the best way of controlling the disease after an emergency response?
I guess that implicit in the question for me is the notion that in the case of SARS-CoV-2, it was pretty obvious that a single protein was going to be protective based on its enormous similarities with the original SARS virus from earlier in the 2000s. I think with a truly new pathogen, even if it's part of a known family of viruses, let's say, it may not be as clear what antigen is worthy of mass producing immunity against. And there are also safety issues, which I don't think can be appropriately evaluated in the absence of any sort of pathogenesis work. And some of the people who were pushing the 100-day idea, one guy in particular from MIT, I don't know if he was part of that, I don't think he was on that paper, but Kevin Esvelt from MIT was suggesting that there should be no live animal work with new viruses. There may be cases where that would be too dangerous, but it seems to me it's kind of dangerous to produce a vaccine that you disseminate widely and immunize millions of people with before you know what the range of possibilities are with a given virus based on your own law, which was that any virus can do anything.
Well, I understand your point, but in 100 days, you can do animal studies, and so you can get some safety data in animals, and you can still do phase 1 studies in a small number of people. But, I think the point that I'm trying to make is that there should be different approaches to emergency and to long-term control. You do what you can as quickly as you can to provide an emergency response, but meanwhile, you're studying the biology and so forth, and calculating what, in the long term, what is the best vaccine approach to a particular disease. I guess an example would be the monkeypox situation in Africa. I think, in retrospect, an mRNA vaccine definitely would not have been the best, but it might have been a way to save lives originally in the first instance. But, or clearly, and in the long run, an mpox vaccine is not going to be an mRNA vaccine. But getting a lot of people protected in a short time, it might have been a quick way of doing that. But the advantage, the thing that I would say that's remarkable to me personally, is that when I started, there was basically attenuation or an activation. But now you have multiple technologies, which is great for developing different vaccines.
We've all seen persons who've had multiple instances of COVID, multiple over time. And is this primarily viral evolution? Is it a non-durable immune response, both to vaccine and perhaps the natural infection? And what should we be thinking about in terms of herd immunity to COVID-19?
People do get reinfected because you have a disease that is primarily a mucosal infection, and we don't do very well in protecting the mucosa. This is probably the biggest area of ignorance in vaccinology, how to induce mucosal responses. I'm very intrigued by the approaches that are at least being worked on research-wise of combining a poxvirus approach with stimulation of antibody using, let's say, mRNA or some other technologies. In other words, stimulating both cellular immunity and antibody immunity, because that is more natural, so to speak. I mean, the combination of the two gives you the best natural immunity. And we need a lot more work on the mucosal part of it. Now, of course, we know that live viruses given on the mucosa do stimulate mucosal responses, but we don't have safe live viruses for every disease. So the issue is how to safely induce mucosal responses. And at the moment, I would say that our knowledge of that is very primitive. We just don't know the best way to do that, aside, as I said, from a live agent that's multiplying locally on the mucosa. So this, to me, is one of the biggest areas of ignorance we have in vaccinology.
You mentioned briefly the role of poxvirus. So what do you think about a DNA platform for immunization? Do you think that they are valuable? Do you think we can generate a good DNA platform for immunization?
Well, we have a DNA platform. The problem is that it requires an apparatus for giving it in intradermally, et cetera. And, the people at Wistar Institute, where I'm associated, have long worked on this, but it hasn't gone anywhere in a practical application because the idea of needing apparatuses to give intradermal injections is just not popular. I'm still consulting for that group and trying to develop better ways to make use of the DNA platform, which has, a lot of appeal. And it does give good cellular responses, but so far we haven't gotten beyond the need to have an apparatus to give the injection.
You had earlier mentioned that you worked on polio when you were at Wistar, gotten involved with Hillary Comprosky's program. I'm just wondering how you think about the trade-offs in general between live attenuated and subunit or other non-replicating vaccines. And I guess the most prominent example of the risks of live attenuated is polio, and in the context that Michael previously alluded to of immunocompromised patients where you can actually get polio spread. So what are your most recent thoughts about, for example, the polio virus situation, where there's still argument about stopping Sabin vaccination and salt and so forth?
Let me put it this way, that the oral polio vaccine was tremendously valuable in stopping the outbreaks and the spread of polio viruses. And so from the public health point of view, it was a tremendous success. However, in the US, as time went on, wild polio disappeared, and what was left was the 10 or so cases a year of vaccine-derived polio, which became unacceptable. And so there was a switch to IPV and the eradication of polio from the US and the Western Hemisphere. Now you have the situation where wild polio persists in a small part of the world. Lots of people are receiving attenuated oral polio, and more paralysis is being caused by the oral vaccine than by the wild virus. So it's time to switch our strategy. And so at this point, what I and others advocate is that IPV should be used as widely as possible, preferably in combination with other pediatric vaccines, and that the use of live oral polio vaccine should be discontinued as much as possible because it's causing more disease than the wild virus. So it's an example of how recommendations change with the public health situation. If every child received IPV, you could even give OPV later in life because they would be protected against paralysis. So you could use both on the condition that the child had the induction of antibodies before being exposed to the OPV.
I guess the next question had to do with a recent paper, which you may not have seen. just in February of this year, where a group of collaborators at Stanford and I think at Pasteur, Yasmin Belkade and Michael Fishbach at Stanford, came up with the idea of using a vector that would infect commensals in the skin to immunize against true pathogens that could cause skin infections. Did you happen to see that paper?
No, tell me about
So the
it.
basic idea, I'm not expecting you to critique the paper. I just want to know what you think of the general idea. Their idea was to use, a cleverly designed vector to get into commensal skin microbiota, staph epidermidis, and use that to immunize against potential skin pathogens, in some context where that was a risk of significance. I just wanted to get your reaction to that concept.
Well, it sounds like an intriguing idea. So it would be an organism that normally lives on the skin, which is not a pathogen, but
Yes.
which is producing some protein that protects against another agent that
Yeah,
is.
it's essentially sort of like an mRNA. I don't remember the exact nature of the vector, but it's sort of like an mRNA vaccine in that you're using the host to actually biosynthesize the relevant antigens. But instead of using host cells, you're using microbiota passenger cells.
Well, sounds like an intriguing idea.
I mean, people have also talked about that in the gut, but I just thought it was an interesting wrinkle that I had not seen before. You've already indicated your understanding of the importance of eliciting strong cell-mediated immunity along humoral. And in fact, I did my graduate work at Wistar with Peter Doherty, and we were focused on the T cell response, CD8 positive T cell response, in particular to influenza. So although it was clear that CD8 T cells couldn't prevent infection, they were quite important in resolving infection. I think that was one of the main lessons of that model.
Immunity is complex, and this is maybe irrelevant, but I was approached recently by a company that has a system of measuring antibodies to vaccine antigens, and their idea was that people would be tested for antibodies, and if they were lacking an antibody, that would be an indication for re-immunization or whatever. And the problem was that one of the antibodies they were testing for was a human papillomavirus antibody. And, and I had to point out, well, antibody fades, but we know from long experience, because of the long incubation period of the virus, that there's a memory response years after the initial vaccination. And so you don't need revaccination because the memory response is there and it protects you against the disease. So obviously they were not happy with this, but what one has to think about the immune responses and what correlates with protection rather than simply having a number.
So talking about multiplicities in clinical practice, we often immunize with more than one immunogen. Is there a limit to how many we can apply to a person at any one time? And if so, what would that limitation be?
That's a good question, and the only answer I can give is whatever the limit is, we haven't reached it, because people are getting now, can't give you a number, but they're now receiving really large numbers of antigens, and so far we have not seen a limitation.
And that's primarily in children, right? In pediatric
Yes,
practice.
yes,
What
yes,
about in the military? Aren't they immunized with multiple immunogens at the
yes,
same time?
yes,
Oh, that's
Yeah.
a good point. Yeah.
So
yeah.
maybe the issue is primarily one of tolerance. How much of a sore arm can you tolerate?
Along the lines of what you're saying, there is now an important need to combine vaccines because of the resistance people have now to multiple injections. I've witnessed and heard and responded to people complaining about the number of injections that their child is getting. And, I understand that. And so companies are working hard on trying to combine as many antigens as possible. And as we were just saying, so far, we haven't reached a limitation for that. But it becomes very important from the public health point of view that if people start objecting to the number of injections, obviously that reduces the coverage. So we need combination vaccines.
So before I turn this over to Neil, is there evidence for cross-vaccine enhancement such that the concurrent administration of an unrelated vaccine enhances the immune response to the other vaccine? They may go to lymphoid tissue, they may go to marrow. Is there the sense that giving more than one enhances the response to the other?
The answer to that uh, could become evident in studies comparing multiple antigens with single antigens. I'm not aware of any data suggesting that, but it's a good question, and it could be answered by companies developing combination antigens and comparing them
Yeah,
with
I think it
single
is.
ones.
I don't recall ever seeing a paper about that topic, but doesn't mean
Well,
it
the
doesn't
experiment could
exist.
be designed.
Yeah.
Yeah.
I have a quick comment on that, though. Years ago, and for many years, I had a tiny papillomavirus, I presume papillomavirus related lesion on one of my fingers, on the exterior surface of my left index finger. It was like, less than a millimeter across. And then I got the shingles vaccine,
Yeah.
completely disappeared,
Uh-huh.
Wow.
totally gone.
Wow.
And I thought that was, it's a one-off. I don't know if it means anything, but it was truly interesting that it was clearly related to the shingles vaccine, the
Temporary.
Shingrix. So I don't know
Wow.
what that says about cross-reactivities or innate immunity or what, but it was an interesting, relevant, maybe irrelevant, but potentially interesting anecdotal observation. Do you have any general comments you think can withstand scrutiny about infection-induced versus vaccine-induced immunity to the pathogens for which we typically immunize? I know that there was a political valence to that for a while. I'm not interested in that so much. It's just your thoughts about that, whether there's any reliable difference or whether you think it's very context dependent.
Well, with the vaccine, usually you are selecting the antigens that you think are most protective. Obviously, with an agent, you're getting all of the antigens. So I suppose there might be some argument that getting the disease gives you better protection than getting the vaccine. But obviously the cost of that is the disease, and what clearly what we do in the lab is to try to find the antigen that most corresponds with protection. And so without using the other antigens, which may also induce reactions. So, it's a trade-off, but I think the practical results are evident that protection can be achieved with a single or maybe 2 or 3 antigens without the cost of reactions induced to other parts of the agent. So, uh, maybe theoretically, disease-induced protection is better than vaccine-induced protection, but then, of course, you're paying a price.
One thought I had is that in addition to what the points you've made, which seem correct to me, there's also the fact that pathogens are often selected to be able to subvert various immune responses. So that
Yeah,
while
yeah,
it's true that you're obviously getting the more natural assembly of antigens with pathogen infection, you're also subject not just to disease, but to other mechanisms which may not be visible that are undermining your immune response.
yeah,
HIV is a classic example there, Neil. There you've got a
Yeah.
pathogen that potentiates its pathogenicity by the cells that it affects directly and indirectly.
Right.
When we immunize, we typically use an adjuvant. So should all vaccines contain an adjuvant? And if so, have you a favorite or a favorite in one setting versus another?
Well, the last question is easy to answer. No, I don't have a favorite. I think one of the positive things that's happened over the years is the development of new adjuvants beyond aluminum. So now we have multiple choices, which is valuable. Yeah, I did work in the past with an MF59, which I thought was really good and would seem to be less reactogenic than aluminum. So I'm very much in favor of developing a wide range of adjuvants because I think there are differences and of course differences in reactogenicity. Rather than being against adjuvants, as some people are, I think the more the better. And there's now a really quite a long list of adjuvants that can be used.
Can you tell us why the standard influenza vaccine did not have an adjuvant? I'm just curious if you know what the consideration was.
I think it was to avoid or minimize any reactions that might occur. No, influenza vaccine is really irritating in many ways. I think
In a non-immunological sense.
we could definitely have better influenza vaccines, but for reasons which are not entirely clear to me, the companies have been reluctant to really get into the depth of influenza vaccinology.
Maybe it's because it's an annual vaccine that, an annually recommended vaccine that if it had a lot of reactogenicity would probably have even lower uptake than it currently does.
Yeah, could be, but based on the science, we could certainly have better influenza vaccines. We have.
I wanted to know why you wanted to learn to fly and why you find flying a source of gratification.
I originally was going to go into the Air Force.
Right.
When one of the reasons being why I wanted to learn how to fly. But then, of course, that got sidelined. So when I was, I forget exactly, 70 something, I decided to learn how to fly locally. There's an airport that's about 5 miles from where I sit. And so I went there and took training lessons and flying and eventually bought a single engine plane. Why did I do that? Because of the feeling of lifting off the earth. The moment of leaving the ground is exquisite. To imitate a bird and to be able to see the earth from above is really different. Of course, in the commercial plane, you just don't have that experience anymore. I mean, it's a terrible experience now. But in a private plane, you can really see things. It's not just a practical thing, it's the sensation of being in the air and lifting off the ground, which is just something that I wanted to experience, and I loved it, and I was doing it. I gave it up because you have to have quick reaction, and I realized that I couldn't do that anymore, and so it was safe
Well,
up.
I'm just struck by the fact that not only are the pathogens you study airborne sometimes, but so are you.
Yeah.
So after that beautiful answer, I even hesitate to ask the bonus question. But since I'm a senior editor, I'm going to ask it anyway. I understand grew up in New York, and I'm guessing that you grew up in the Bronx. So my
That's right.
question is, are you still a Yankees fan? And if so, why?
Well, I guess you could say, formally speaking, I'm still a Yankee fan, although, you know, I've learned over the years that these guys are not New Yorkers. They come from all over the world, that they are essentially getting a lot of money for a job. And so I'm not the fan that I used to be. But when I was a kid, I was definitely a Yankee fan. And,
Well, it's good to hear that your allegiance has changed, if not in both magnitude and phenotype.
yeah, yeah.
So, Dr. Plotkin, thank you so
Yeah.
much for speaking with us. It was truly wonderful. I think I can speak for Neil and the other editors of the journal
Yes.
that we're so pleased that you were able to spend some time with us.
Yes, it's been a real delight and a privilege to have a chance to speak with you about
Oh,
vaccines.
thank you.